I have to tell you that I'm actually pretty blown away myself, and I'm almost speechless, which my team who's here will tell you I really never am. But the excitement in this room, what we've heard from our governor, what we've heard from our legislators is just absolutely inspiring, really, at every single level. And I know for me, for somebody who started my professional life in the mental health profession, hearing and seeing, and it's just beyond comprehension. And I know on a very personal level the cruelty that takes place when people's needs aren't met and the financing isn't there. You know, I watched my aunt, my dear, wonderful, amazing aunt who went through a psychotic break, chained in a hospital emergency room because there were no geriatric beds, and that was 18 months ago. So I feel your pain, and I wish that I could do more, and I feel excited about the fact that I think I'm going to be able to do more. So I'm really just shaking with excitement. But what I was asked to do today is just to take a minute and talk in a practical way about sort of some of the regulations that we've been able to put into place, because these amazing legislators pass good, strong legislation, and then it has to be enforced. And that gets enforced through a regulation process and through the agencies. And the Maryland Insurance Administration is, at least with respect to the commercial market, one of the places where that happens. And so there are two things that I just want to touch on briefly to give you guys an update. And your group has really been instrumental in allowing these regulations to take shape. And I mean that very sincerely, because both with respect to the network adequacy regulations and with respect to the mental health parity regulations, we went through very long iterative processes of posting the regulatory work, listening to comments, having multiple stakeholder meetings. But time and time again, it was really your organization giving us its insights that allowed us to move forward. And the reason that we have what I agree are really groundbreaking, probably best in the nation regulations right now are in large part because of many of your members. And I'm going to give a special shout out to Dr. Harbin, who really has been the heart and soul, and not only in terms of giving us his wisdom and his experience in getting these standards in place, but also, to be perfectly honest, when we couldn't get people to come help us to actually take those reports and evaluate them, and we couldn't find at our cost the folks to do that, he helped us find them too. And Beth Ann now works for us as a contract employee, but she's amazing. So we couldn't be doing the work that we're doing literally without this organization, this group. So just very briefly, let me talk about the mental health parity status where we are right now. So as you know, in 2020, the legislature adopted the reporting requirements for MHAMD, focused particularly on the NTQLs, very specific parameters in terms of what those reporting requirements needed to be. The direction was for the MIA to adopt regulations. First reports were due on March 1st, 2022. We went through what was for some people a very painful process, but a very detailed and deliberative process, and we have those regulations in place. They became law on December 31st, 2021, and the first reports were due on March 1st, 2022. So I'm just going to give you a brief update on where we are with them. The MIA received 213 plans from 17 different carriers. And our initial review identified that there were some carriers that didn't make the filing deadline at all, and others that didn't submit the right reports for the right entity. So we went through a process, and we issued orders with substantial penalties for those people that weren't able to read the law. Then we moved into our second phase. So the second phase has really been the deep dive into those reports and the data that's been submitted. And we are working with the contract employees that I mentioned, many by virtue of Dr. Harbin, thank you, as well as our MIA staff to review the reports and the data for completeness. The reviews are thorough and they are painstaking, and I'm disappointed because in general we're finding significant deficiencies in how data is being reported. Those deficiencies are being documented in very lengthy, very clear, and very detailed letters. One of them was 90 pages long. that provide carriers with one opportunity to correct their submissions. That 90-page letter, that represented 200 staff hours, just to give you an idea of what that is, and that was one carrier of 17. So that approach, while it feels lengthy, serves two purposes. The first purpose is because I want the information. I want it. And secondly, because I'm going to be crystal clear about what is required, I will have the basis, if they don't submit it in that 30-day turnaround time, to issue the very substantial penalties that were contemplated by the 2020 law. I can also share with you that we are now in the process of evaluating the corrected submissions. We continue to see significant deficiencies, and we are in the process now of drafting orders to identify those deficiencies and impose substantial penalties. Once we have complete reports, we will be able to evaluate whether health plans are actually complying with the law by implementing NTQLs appropriately. And if I don't get the data, then I'm going to draw the conclusion that they are not in compliance because they're not able to submit the data. And then we will fine and act accordingly from there. So that's where we are with MHAMD. And again, many thanks to this organization for the ability, because of where we are right now is in large part because of the support that we're receiving from the professionals that are part of your organization. Second update is on network adequacy. When the MIA, promulgated its regulations in 2017 with initial reports due in 2018, when I arrived on the scene in the beginning of the pandemic in May of 2020, one of the first things that I heard about from your community was the fact that there hadn't been a lot of movement on those reports. And so I asked you for a little bit of time and a little bit of grace, and you gave me that. We dug in, figured out what was going on and what the problem was and why they weren't being reviewed. And we discovered that we had to go down two pathways. The first pathway was that we had to move on the reports such as they were. But we also understood that part of the reason for it was because the regulations needed to be updated and revised, and not only in terms of the actual standards, but in terms of the reporting modalities and really cleaning it up so that it was really clear and nobody could wiggle out around the information. So we went down those two pathways. With respect to the reports themselves, with respect to the standards that were in place under the 2017 regulations, what we have found is that most of the plans, so 25 access plans were submitted, 17 were fully compliant. And that was a difference because our 2019 reports, lots of deficiencies. Because of the time drag, we issued consent orders. We suspended the fines and said if your 2021 reports show that you fixed it, we're not going to impose the fines. Many companies were able to meet those requirements. Some didn't, and we have imposed fines on those that didn't, and some got worse, and then we imposed bigger fines. This year in 2022, we're seeing a little attrition, and I'm not sure exactly what the reasons are. Across the board, the wait time metrics for mental health, substance use disorder have slipped in 2022. So we're trying to dig down into why that is. I think it's a provider exhaustion issue, but I'm not entirely sure about that. So we're looking at that. But really, most importantly, what the MIA has done is it's revised the network adequacy regulations. They have been submitted. They will be published in the Register on February 24th. 30 days after that, they will become law and they will go into effect. There's sort of a split timing around when the regulations are there. Specific to mental health needs, there were really two things that I wanted to touch base on. First, and I think very importantly, is that we've recognized additional specialties in mental health with distinct standards. So new specific travel standards for mental health practitioners, including child psychiatrists and geriatric psychiatrists. And then the last thing that I'll just mention is that we do address telehealth. And I know there was a lot of controversy and a lot of concern about how we were going to handle telehealth. There is the need to recognize the importance of the role that telehealth plays, but we also have to be really careful to be sure that no one is forced into telehealth, and we have to be sure that if it counts against adequacy standard, that it's done so with evidence that it's available to people and it's medically, clinically appropriate. And so our standards take that into consideration, and they require companies, they entitle companies to a certain percentage of credit for making telehealth available. But in order to get that credit, that's a bar of information that they have to provide about availability and the propriety and appropriateness of its use in that space. The last thing that I'm just going to say to you is that one of the things we have noticed at the MIA with our appeals and grievance and our life and health complaint units is the increase, the uptick in what we label behavioral health, complaints and outreach, and we're seeing more of that. So we're working on our data to try to identify what is driving that and what the kinds of claims are and the kinds of issues are. We want to continue to partner with you on education and collaboration and connection. So as we work through many of these issues, the MIA, working with, and many of you know Joy Hatchett in our CEAU unit, partnering with HEAU, the Attorney General's Health Education and Advocacy Unit, and other parts of state government, we can do more. We can do more within our current remit. And we need to spend more time with providers to enable their patients to have better access to those services that do exist and where state can help. So with that, I'm just going to say, again, I'm incredibly honored to even be in the same room with the people that have already spoken, because I'm kind of chopped liver compared to them. But I'm really, really excited about where I see us going, and I thank you for the opportunity to share what the MIA is doing.